And what we might do, I'm trying to keep to time, is we might just move straight on to our next speaker. And that is Susan Hemo. Have I pronounced that correctly, Susan?
You have.
Great. And so Susan's presenting on the role of familial carers in palliative care for terminal cancer, the ethics of autoethnography. Just over to you, Susan.
Okay, I'm just seeing that I can, get to the beginning. And, okay, slides are good?
Yes, they're great. Thank you.
Okay, so this is a little bit of a shift from clinical trials. This is actually a deeply personal research project. So in mid-2024, my husband was diagnosed with a really nasty cancer. He'd had prostate cancer for about 12 years previously that was stage 4, but this was a new small cell carcinoma with unknown primary. And so I became his primary carer, but I'm also a researcher. So I decided to critically analyse and research the work of actually being a carer. So when I started looking at the literature, I found that there was very little, there was a lot of material on the mental health of carers and quality of life and issues of distress, but very little on what carers actually do. So I decided that I would do what is called an autoethnography. So for those of you who aren't aware, an autoethnography, it's kind of made up of 3 bits. So there's the auto bit, which means self, the ethno bit, which refers to culture, and graphy, of course, means writing. So it's writing about self in the context of sociocultural and historical situation. It's an accepted method in the social sciences, and it's becoming more common in health research recently, like in this last decade. And you can see on this slide, I've given this example that it's kind of been split into 2 different camps, sort of the more evocative autoethnography, which focuses more on the self and the emotions and the experience, and there's a more analytical type autoethnography, which is thinking about, asking broader questions about systemic factors through an autoethnography. So what I'm going to talk about here is not the findings from the autoethnography, because it's an ethics conference. I'm going to talk about the ethics of the autoethnography. And in the literature, you sort of get 3 positions. One is that, it's literally not questioned. There's either no mention of ethics, there's no review, and so forth. Or you get an absolute flat no, it's impossible to write and publish an autoethnography ethically for various reasons. And then you get a yes through various means. So there are some people who say you take a checklist approach with a number of issues, or you go through a process of sort of mindful review, which was one of the things that was brought up on Tuesday, I think, mindfully thinking about ethics. So my approach was to actually go through and ask for ethical review of my project. And in this presentation, I'm going to cover a few key issues around merit, who owns the story, issues of consent, confidentiality, and research and life boundaries. So you may be asking at this point, why on earth would I come up with this project? Most people don't find out their husband has terminal cancer and decide to do research on it. However, I am a medical anthropologist by trade, and I've worked a lot in Papua New Guinea, and some of my key research has been on cross-cultural issues of death and grief, emotions, but also access to medical care. I've worked across communicable, non-communicable illnesses, maternal health, and so forth. I've also written around the ethics of research, and I have been a HREC member since 2020. So you can see that where I'm sort of coming from. So I am an ethnographer by trade, but I'm also really interested in ethics and healthcare and so forth. So of the issues around the ethical issues that this project brought up, so this was actually the hardest ethics application I've ever had to write because I had the most skin in the game. I remember walking up and down, North Terrace as I was sort of planning my ethics review, and thinking about the issues really deeply. Some of what I raise are in the literature around autoethnography and some are not. So one that often doesn't get brought up is about merit. So clearly the national statement says that research has to have merit. And there's this debate about whether autoethnography is just navel-gazing and egotistical. So Greiderhall says you can't do this ethically because you're just writing about your personal feelings. Now, the original Greek translation of this is omphiloskepsis, which is meditation on the navel in order to understand yourself and your position in the world. And it was not considered to be a serious problem. My focus in this was not about, gee, how did this feel as a carer? Was I upset? That might have validity for some people to write about that. I was really interested in, through this process of my husband being unwell and me being a carer, how was knowledge shared between the health professionals and us, between us and so forth? How did we make decisions, or when did we get to make decisions, and how were they made? A lot about the experience of time and waiting, and a lot about the experience of the work of caring in terminal cancer. So in recent days, we've heard some stuff about things like mystery shoppers, to get a sense of, how people's experience is going through the healthcare system. But that doesn't really get at the experience of the patient. It gets at how well the health system is functioning, but not so much about patient experience. I could have perhaps done interviews with people, but interviewing people who have a loved one with a terminal illness is also really challenging emotionally. So this is why, for me, an autoethnography was a good way at getting at this. And the ways I did it, I wrote the ethnography in a way I would have done in other ways. So I took detailed notes, handwritten short notes, often at the point of a medical encounter, written up into longer field notes. I collected ephemera, so scan reports and so forth. I also kept a journal, but that's kind of normal, and that's not part of actually the research, but it is there if I need sort of the emotional context of what was happening. So the issue of whose story is it? So some people who are writing autoethnography say, I'm just writing about myself. There's no need for ethics review. However, I would argue there are always other people implicated in our stories, even when we write an autobiography. Life is a social process, and we don't have an inalienable right to tell the stories of others, as Ellis says. So this was the story of both myself and my husband, but also the people around us. Some of the literature says you can use polyphony to give other people a voice within the story about how their experience was of this process. But what you do when, for example, for me, my husband was not a writer. He was never going to write anything, nor would he really have felt comfortable being interviewed. And, when he is no longer here, how do you then include that person's voice? So that issue of whose story is really an interesting one. The third issue is consent. So for me, this in the actual writing of the ethics application, I thought about consent of myself, consent of my partner, children, and health professionals and allied staff. For me, my husband and I discussed this from the get-go. So we met when I was doing my doctoral thesis in Papua New Guinea. He knew from the get-go I was a researcher. He was very much aware of all that I did. So we sort of talked about, was this a possibility? And he said, yep, go for it. Who else is going to do it? So I would never have done this without that. In the actual ethics application, I was required to write a consent form for myself, which is one of the funniest things I've ever had to actually do. So I had to state that I had read the attached information sheet that I'd written, and I have designed it, and so forth, and then I signed my own consent. So there was obviously conduct implying consent by writing the research, but there is the formal consent form as well. My husband, I wrote a PIS for him, but informed the ethics committee that it was very unlikely that he was going to read it. I could read it to him, I could explain it, which is what I did, and he signed consent. During the process of him being ill, he was also enrolled in an actual another research study, a medical research study. He didn't read the PIS for that one either. I read it. I watched the video. I explained it to him. I said, "Do you want to look at it?" And he's like, "Nah." He's like, "Just give me the form. I'll sign it." Yep, let's do it. So that was a separate project run out of a different group. For children, so my husband was the father of 5. So I have two stepkids. 4 of the children are actually adults. A couple of them are in their 30s, and there was one underage child. And I purposely didn't invite them to be part of the project. I let them know that it was going on, and I'm always very open to them giving me feedback about, don't say that, don't include this, don't say that about our dad, and so forth. If they insisted that they wanted to be part of it, I would have then got them to be part of the project. The committee feedback was that they suggested that someone else should be brought onto the research team to consent them into the project. I couldn't work out how to do that. It felt really weird, so I left that. Finally, health professionals. There was all these people that were part of the health encounters. So there were stacks of specialists involved. There were the fill-ins when the actual specialists were unwell. There were a whole range of nurses, public hospital, private hospital, technicians, receptionists. Sometimes I didn't even know these people's names. So where people were standard specialists or doctors, they were given the PIS and consent form to be part of it. So that's how it was dealt with. So confidentiality and privacy. Clearly, as an autoethnography, the confidentiality is impossible for myself and my husband, and that was stated up front in the ethics application. For medical professionals and allied health staff, I'm not naming clinics and hospitals. I'm trying to disguise gender, but it's clear on the PIS that it's possible for them to potentially be identified. And then there were all these peripheral players that I didn't often know their names. So technicians, people who drifted through, took a blood sample. I just don't describe them in detail, so there's no way to actually identify them. So my key focus was really on not the actions of individuals, but systemic factors, watching time. Research life boundaries. Initially, when I wrote this, I was like, oh, there's going to be research and there's going to be life. And I'll focus on the medical encounters, but in reality, it bled through into other areas. So it's a really interesting thing. And when I was preparing this, I thought about putting up a photo of my husband, but on the ethics application, it said I wouldn't take photos. So I have photos during that year that he was unwell. but they weren't research photos, so there is no photo of John up here. So conclusions quickly. I think ethical ethnography is possible. It's very challenging depending on the topic. And I think it's really important to think about merit before we do it, and design really carefully for issues of consent, confidentiality, and really think about protection of the researcher as both a subject and a researcher at the same time. Careful review with a HREC that has experience. And there are a whole bunch of references, and thank you.
Thank you, Susan. What a beautiful piece of work, and I just want to acknowledge I'm very sorry to hear about your husband. It's very brave what you've done, and also very impressive. So thank you for generously sharing your work. We'll move on to the next speaker in the interests of time. Susan's left her contact details there if anyone would like to get in contact with her. Thank you, Susan. So